Hi, my name is Josh and I'm an F1 doctor in Bristol, and today this is a 10-minute presentation on hypo and hyperkalemia. Of course, it's not going to cover everything in it, but it will cover the basics and what I think are the key things for tackling hypo and hyperkalemia as a foundation doctor. So throughout this presentation, it's important to remember the basics of your physiology, and this really is the basics. This isn't physiology at its best, but remembering that alkalosis, insulin beta agonists, move things from the extracellular fluid into the intracellular spaces, and acidosis, hyposmolality, beta blockers, and cell damage move from the intracellular to the extracellular spaces. From the extracellular spaces, potassium is excreted via both the stool or the wee. So first off, we're going to spend the first portion talking about hypokalemia and its definition. So first off, hypokalemia is defined as mild, moderate, and severe. And really what we're concerned about is obviously the severe and moderate hypokalemias, but very common on the wards to get sort of a mildly deranged, a mildly sort of 3.2 or something hypokalemia. And really, I'm not going to touch on the symptoms, but what I will briefly talk about is the causes. So of course, sometimes, it can just be a one-off. Perhaps they were given too much fluid without potassium in. And sometimes this is a recurrent thing. And when it's a recurrent thing, you might need to talk about the causes a bit more. So you have things like diarrhea and vomiting. You have things like, an alkalotic state or given too much insulin, overtreated for hyperkalemia, for example. Or perhaps they're given TPN and things like that, or various different things. But essentially, these are quite rare to even be thinking about the causes as a junior doctor, but it's important to bear that in mind. Now, with hypokalemia, as I said, it's really, really common to get like a potassium of 3, and it's always best to look at the trust guidelines. But broadly speaking, if it's a mild or moderate hypokalemia, you'll be thinking about giving something like Sandoz, and there are other sort of modes, other different tablets or liquids you could give with potassium in. The most common is Sandoz, and you give something like 2 tablets, so 2 Ts, 3 times a day for, a review in 48 hours or 3 days, something like that. If it's really low, less than 2.5, then you'd be thinking about IV replacement, something like 40 millimoles in a litre of normal saline or glucose. And of course, just giving that over 4 hours as the max administration of potassium is 10 over an hour. It's also worth noting that some patients can't orally take, perhaps they have dementia or they have a poor swallow, in which case you'll just need to do IVs. And actually Sandoz is really disgusting, so some patients just won't tolerate it, and if you've got a few days of them just not tolerating Sandoz, then you might need to give some IV replacement of the potassium. So that's it on hypokalemia. That's the first bit, and we're going to spend most of our time now on hyperkalemia, as it's not only the sort of more common presentation, the more common electrolyte abnormality, but it also is more severe in terms of its effects and its danger. So as starting hyperkalemia, the definition, mild, moderate and severe, and really what we worry about is anything over 6. Anything over 6 needs your attention to be sort of brought to the patient fairly quickly, and you need to do a few bits. So if someone, often this gets rung through to the lab, to the nurses, and nurses will bleep you saying, the lab's phoned and said her potassium is 6.2. What are the first things in your mind? The first thing I always do, particularly if the blood test was sort of really difficult to take, is get a repeat, and that can just be a gas sample. If the repeat shows that potassium is also 6.2 or 6 or, something in ballpark, then, treating is really reasonable as well. Sometimes you get potassium of something like 10 and you think, really? Really is the potassium 10? Well, you've got to take it seriously, but repeating a sample, and if it's also high, then, you have to take it seriously. But repeating a sample is always a really good thing to do. Getting an ECG, just asking before you arrive, is another really good. So potassium over 6, repeat the sample, even with a gas and a lab sample and an ECG. Let's think about the causes then. I mean, we mentioned earlier about a difficult blood test, tourniquet time, being on for a long time, that causing a pseudo hyperkalemia. We also have things like leukocytosis. I've had this in one patient where we sent several samples to the lab, and actually, because there's so many leukocytes in the blood, it causes a derangement in how the blood is tested in the lab, and sometimes we prefer then a VBG sample would be more accurate in that. You can also send a different bottle top. The lab can do a different test. So repeating that sample. As we mentioned earlier, acidosis and drugs can cause an intro to extracellular shift. All your renal stuff, your ACEs, your ARBs, and obviously just giving too much supplementation. And then the other things, these are presentations, tumor lysis syndrome, rhabdo, crush injuries, things like that can all cause hyperkalemia. So how do we treat? I mean, there's lots of different guidelines, and there are lots of different things we'll be doing. This is sort of an accumulation of lots of different guidelines that I've seen and researched online. And it really very much depends on mild, moderate, severe. So mild, I'll be thinking, should we just repeat the sample? If it's 5.9, let's repeat a gas sample, see how it is in a couple of hours' time. If it's 5.5, I don't think, let's just put bloods out for tomorrow and see where the potassium is trending. Obviously, depending on the patient you have in front of you. Moderate and severe, I get an ECG. ECG, if there's any ECG findings present, then I give calcium gluconate IV. Some give 10% or 30 mils of 10%, depending on the presentation. And what I would say is, if there's any weird ECG changes that you're not sure about, ask your senior first off. But actually, you won't do too much harm by giving calcium gluconate. So, if there is doubt, I would probably give it. I'd also obviously get the patient cardiac monitoring if there really are truly signs of hyperkalemia on an ECG. The first stage of treatment, not just about stabilization of the cardiac membrane, that's what they talk about with calcium gluconate. The treatment of potassium, and it goes back to that physiology right at the beginning, is obviously giving soluble insulin. So 10 units of insulin in 50 mils of 50% glucose. And if the pre-treatment glucose is less than 7, then you also give dextrose as well, because obviously you worry about causing a hypo. You do that, you'd retest the potassium. If it's still high, then you can consider salbutamol and repeating that lot of insulin as well. And then the third stage would be doing other things. So you'd be contacting seniors at this point, speaking to renal, but using something called sodium zirconium or Hyperkalemia. 10 grams of a sachet mixed in water 3 times a day. Do that for a couple of days, then go to sort of 10 grams once a day and then 5 grams once a day. That is a potassium binder in the gut, reduces the amount of potassium that's able to absorb through the GI tract, and therefore reducing the amount of potassium. And that can work fairly quickly, actually. So if you're having someone with refractory hyperkalemia, you may need insulin, salbutamol, and sodium zirconium, or the Hypokalemia, the brand name. As I said, if that's still refractory, you're going to be needing to talk to renal, ITU, or your seniors. You've got to think about discontinuing offending drugs, as we mentioned earlier, your ACEs, your ARBs, your heparins, reducing the dietary intake, thinking about bicarb, which is also an option, particularly if renal are keen for that. And if it really is refractory, then hemodialysis. Refractory hyperkalemia is an indication for hemodialysis or hemofiltration, getting that potassium down quickly. We'll talk briefly about the ECG changes, and I mentioned earlier about the fact that, if you're unsure of ECG changes and there's not an immediate person to ask, then I would just give calcium gluconate. I don't think you'd be penalised for that. I do always think in my head of the ECG changes as pinching the T wave up, and then just before the P wave, pulling it down. So you get that prolonged PR, the broadened QRS, and the peaked T waves there. But actually you can get bradyarrhythmias, conduction blocks, and sort of lots of weird stuff happening. If in doubt, give the calcium gluconate and treat with hyperkalemia, if it truly is that. So that is a 10-minute summary of hypo and hyperkalemia. I hope that was useful, and do check out the other stuff on 10-Minute Medicine. Thanks.